So welcome back. I want to remind you to interact with us on social media. The Twitter, X, Facebook handle is at Great Debates CME. And again, remember to tag your posts with hashtag GDULC2023. So I think that before I present Dr. Yu for this session, which is entitled EGFR, the Challenge of Primary and Secondary Resistance, I'd like to turn your attention to the screen where you'll find the answer is you're supposed to find a QR code. I don't see the QR code. So momentarily you will find a QR code. And I take a moment to scan the code or go to the URL listed on the screen. Are we getting the code up? Yeah, perfect. Okay, so take a moment to scan the code or go to the URL listed on the screen to participate in the pre-session survey about the content you're about to hear in this session. The questions are completely anonymous, and your answers will really help the team in tailoring the further educational program, and we really appreciate your participation. And finally, I'd like to acknowledge that the session is supported by an independent education grant from Janssen Biotech. And now I'd like to introduce our speaker, Dr. Helena Yu. Thank you.
Good morning, everyone. Thanks for having me. Okay, so I do think that you guys got a talk on EGFR mutations in general from my colleague, Dr. Riley, this morning. So now we'll be talking about kind of resistance and some other challenges within the EGFR space. Here are my disclosures. Okay, so these are our learning objectives. I will leave them to you to read. Okay, so the outline of what we'll discuss today, we'll talk about secondary acquired resistance. We'll talk about later line treatments in EGFR mutant lung cancer. We'll review primary resistance and then end with some management of common adverse events of these EGFR therapies. So, I'm sure this morning you heard about EGFR TKIs and how they have obviously transformed treatment for EGFR mutant lung cancer. Our best-in-class monotherapy, osimertinib, third-generation EGFR TKI, is extremely effective, but ultimately all patients end up progressing at some point. And so the figure that you see here is our rebiopsy at the time, tumor tissue rebiopsy at the time of acquired resistance, looking to see if there are any identifiable histologic or genomic mechanisms of resistance. And this really can be categorized into on-target resistance mechanisms, and those are acquired alterations within EGFR, like C797S. You can get off-target acquired alterations. Most commonly, this is MET amplification, but you can see strange rare things like RET fusions, BRAF fusions, ALK fusions. And then there's something called histologic transformation, and this is when an adenocarcinoma, which is traditionally typically what EGFR mutant lung cancers are, but we've been seeing transformation to both squamous cell lung cancer and small cell lung cancer, and this happens in about 15% of cases. And then you can see the sort of half of the pie that's gray, and this is when there is a non-genomic mechanism of resistance, or when we biopsy and we do NGS and we don't see anything. So I think the summary or key points here are that mechanisms of resistance, as you can see, are quite diverse. When we had resistance to earlier generation EGFR TKIs, this pie was dominated by T790M, but you can see here nothing is really the dominant mechanism. With better EGFR inhibition, we're actually seeing less on-target resistance, so less acquired EGFR alterations, more off-target. And then compared to earlier generation TKIs, this histologic transformation is more common. And so one thing that we looked at, which I think is interesting, is wanting to know, based on those different categories of resistance, off-target, on-target, transformation, and unknown resistance. Is post-progression survival after osimertinib any different? And we really did not see a significant difference in overall survival based on the mechanism of resistance. But one thing that we did see is if second-line therapy was targeted to any acquired resistance mechanism, if it was present, and that includes histology-based chemotherapy if someone develops small cell, or MET inhibitor treatment if someone has MET amplification, survival, post-progression survival was improved compared to patients who did not have tailored or targeted second-line therapy. So I think the summary there is we don't usually find something that's targetable, but if we do, I would do my best for my patients to try to target it. And so here are some of the things that we can target. So in terms of on-target resistance, there are a slew of fourth-generation EGFR inhibitors that are currently in clinical development that target C797S and some of the acquired EGFR alterations. Interestingly, actually, C797S is where osimertinib binds to EGFR, and so this is different for the earlier generation TKIs, and so one potential strategy is actually to go backwards for people who haven't received them and try a first or second generation EGFR inhibitor. For off-target acquired alterations, if there is a validated treatment for that target, one could imagine combinations with osimertinib. And then lineage plasticity, at that point, it's really just making sure we identify this, because obviously if someone develops small cell, you'd want to give them small cell-directed therapy rather than adeno-based chemotherapy, and same with squamous cell. And so one of the kind of best validated and tested mechanisms of resistance is MET amplification. I think the big question with MET amplification is how to identify it. There is kind of, every study does a different, slightly different biomarker, so it does make it challenging to cross-compare studies, but when using the loosest, lowest thresholds for MET dependency, it actually can be up to a third of patients post-osimertinib have some evidence of MET dependency by, say, FISH or IHC testing. And so this is relevant for a large number of patients. And so there have been several, obviously there are several approved MET inhibitors, including crizotinib, tepotinib, capmatinib, and some investigational MET inhibitors as well. And so you can see here the TATAN study, now kind of surpassed by the Orchard study and the Savannah study, looking at osimertinib and savolitinib post-resistance to EGFR TKI with MET amplification. And you can see the waterfall plot for that. And Insight 2 is the osimertinib tepotinib study. And you can see similarly good responses, you know, approaching 50 to 60% for some cases for some MET inhibitors. The only issue with this is that because the MET amplification is often subclonal and not present in all of the resistant cancer, the responses are not as durable as, of course, what we see with the first treatment with EGFR-directed therapy. But I think something that is emerging and certainly applicable to a significant subset of our patients. And so this is a neat case of mine where somebody developed an ALK fusion as their mechanism of resistance to EGFR therapy. And so based on the emergence of the ALK fusion, I treated the patient with crizotinib. She developed resistance, and then I actually switched to alectinib. And then, you know, when I rebiopsied her, she actually had the acquired ALK G1202R solvent from mutation. So I think super interesting that you can get resistance to resistance. But I think for the right person, these are super rare, but for the right person, you know, these combinations of targeted therapies are doable, and certainly there's been case reports that show that this is effective, can be effective. And so histologic transformation, and so these are different, the figure on the left side is a small cell transformation, and a figure on the right is a squamous cell transformation. And so, you know, these are cases where we went back to the histology and confirmed pure adenocarcinoma in the small biopsy prior to treatment, and pure squamous or small cell lung cancer on the acquired resistance sample. As I mentioned, I think that we're seeing more of this, and you know, this is a real effective way for a tumor to become resistant to EGFR treatment, because when this histologic transformation occurs, that tumor really is no longer dependent on EGFR signaling for growth and survival. And so, it really is a completely different tumor at that point. In general, once transformation occurs, outcomes are quite poor, and it really sort of becomes a de novo small cell or squamous cell lung cancer, which we all know options are more limited. And so I think ultimately for these patients, there really is a lot of effort to identify what are these early drivers of plasticity, and is there a way to prevent transformation, select patients that are at risk, and then potentially prevent it. And I think one of the little hints or kind of possibilities is looking at the genomics of the cancer. So RB and P53 mutations are pretty pathognomonic for small cell lung cancers. And so if people have this EGFR, P53, RB1 triple mutation, those are the people that are at risk for small cell transformation. This is necessary but not sufficient. So it's only about 30% of patients with this genotype that ultimately transform. But that's a hint to sort of look more closely at resistance for those patients. And so, as I mentioned earlier, resistance mechanisms are diverse, and so are going to require diverse treatment possibilities to combat those resistance mechanisms. And so one such study of investigating different treatments is the Orchard study. So this is a biomarker-directed study where we're biopsying people after first-line osimertinib, looking to see, doing NGS on the tumor tissue biopsy sample, looking to see if there is something targetable, and targeting that for those patients that have a targetable resistance mechanism, and for those that have no biomarker identified, giving them sort of thoughtful combinations that are likely to be effective for the majority of patients. And so this study's ongoing. So now moving on to later line treatment. So just to reiterate, there are no approved targeted therapies after osimertinib. So this is a huge unmet need and a space that requires new agents. And so one such agent is patritumab deruxtecan. That is a HER3 antibody drug conjugate. I'm sure you guys are going to hear a lot about ADCs at this conference, because it really is a new wave of sort of a therapy type that I think will be relevant for a large number of our patients with non-small cell lung cancer. So this one has been primarily studied in EGFR mutant lung cancer. HER3 is largely expressed in almost all EGFR mutant lung cancers. And so this agent was studied after osimertinib and after platinum-based chemotherapy. And this is the data from the phase 1 study, which demonstrated a response rate of 39%, a median PFS of 8.2%. I didn't have a chance to update these slides since World Lung was last week, but we did present the phase 2 study of much more patients in a phase 2 study that received patritumab deruxtecan. The response rate was 30%, median PFS of 5.5 months. But I do think quite active in the third line and beyond setting, where we really have minimal options for our patients. And so there's a confirmatory phase 3 study ongoing, as well as a combination study with osimertinib that's ongoing. And another combination is amivantamab and lazertinib that's been studied in this space. Amivantamab is an EGFR MET bispecific antibody, and lazertinib is a third-generation EGFR TKI similar to osimertinib. And so this similarly was given post third-generation TKI after platinum-based chemotherapy. And you can see the response rate, 36%, with significant shrinkage in most patients, and the spider plot below of kind of durable responses in the patients that have tumor shrinkage. And so this is also an ongoing study that's being looked at not only in the later line setting, but also the first line setting. And I think that study should be due to read out soon, so we're looking forward to those results. Amivantamab and lazertinib, in particular amivantamab, because it has MET inhibition as well, you do see MET-related side effects, and in particular hypoalbuminemia and peripheral edema, which can be quite significant for some patients. And there is probably more EGFR wild-type toxicity with this drug as well. And so you can see rash and paronychia. And we'll talk a little bit more about specific AEs later. And then, as I mentioned, there's lots of ADCs that are being studied in non-small cell lung cancer at large, but also in EGFR mutant lung cancer. And so other such drugs are datopotamab deruxtecan, which is a TROP2 ADC that was looked at in they call it AGA, actionable gene alteration positive lung cancers, and then Teliso-V plus osimertinib, which is a MET ADC, and you can see good responses in the setting of combination with osimertinib. So I think we're going to have a lot of options here, which is great. I think that the thing with ADCs that is going to be a question is the possibility of sequencing. If the, in terms of resistance to these ADCs, we really don't know what the mechanisms of resistance are. They might be mechanisms of resistance to the antibody portion, but also could be the payload chemotherapy portion. And a lot of these ADCs have the same deruxtecan or topo-1 isomerase inhibitor backbone, so there could be cross-resistance. And so I think hopefully we'll have a lot of options, and that'll be a good problem to have in terms of understanding sequencing. And then in terms of standard of care, so if a study, since I said no targeted therapies are approved, in terms of standard of care options after first-line osimertinib, it really is platinum-based chemotherapy. One question that comes up a lot is, for our driver mutation negative patients, of course, the standard of care is chemo-IO as first-line treatment. So is this a population where we would want to give chemo-IO in the second-line setting? Just to remember, we cannot combine osimertinib with immunotherapy. There was a high risk of immune-related toxicities, including pneumonitis. And so it's an either-or. And then I think we've learned that answer with sort of recent data, both Checkmate 722 and Keynote 789, which gave chemo plus nivolumab or chemo plus pembrolizumab after progression on EGFR TKI were both negative studies. And so I think there really is no data. Well, there is one positive study with sintilimab, so I think the body of literature really suggests that there is less benefit or no benefit with immunotherapy with chemotherapy. And so this is something that I wouldn't do. And then, continuation of osimertinib with chemo, we don't have the answer to yet. I think that there might be a subset of patients, particularly those with controlled CNS disease, where this makes sense. And there's an ongoing COMPEL study that is looking at that as well. And then when we look at the third line and beyond, similar to kind of driver mutation negative patients, we're really looking at single agent chemotherapies with response rates kind of in the low 10 to 15% rates. And so I think, again, an area where we need new options. I would be remiss to not bring up the potential for local therapy in these cases. And so I think, this talk, I can't talk about everything, but I think that there also is a potential to do consolidation with local therapy for patients with oligometastatic disease at the start. But definitely in the setting of progression on EGFR TKI, we've seen that about a third of patients have oligoprogression, so progression in one or few sites. And those patients definitely, consider surgery, surgery, radiation, ablation, likely radiation to address that oligoprogressive lesion, and then continuing the EGFR TKI makes sense. And for those that have CNS progression, of course, addressing that with radiation and proceeding with the same systemic therapy makes sense. But, and of course, there also is treatment beyond progression. We've all had cases of patients who have pretty indolent progression on EGFR TKI, and if it's sort of changes measured in millimeters, people are asymptomatic. Of course, we can continue, the same therapy beyond progression. And then, of course, if there's significant disease growth or if the patient is symptomatic, that's time to switch and rebiopsying at that time. So I think, this is going to be a complicated, ever-changing space. I don't know if it was discussed this morning, but, the FLORA-2 study came out last week at World Lung, and that looked at osimertinib plus chemotherapy as first-line treatment with a significant PFS benefit. I think ultimately we're going to have lots of choices for our patients in that first line setting, and I think it's going to be about risk stratification, identifying patients that are at higher risk and escalating their therapy, and identifying patients that are more moderate or low risk, and probably continuing osimertinib monotherapy for those patients. And then, in the second line and beyond setting, if there is a driver that is driving resistance, of course, we want to target it. There hopefully will be new targeted therapies that might benefit all of our patients, and then figuring out the best combination of chemotherapy with other agents is another area that we will need to explore. And now to segue to talk about EGFR exon 20 insertions. And so EGFR L858R and exon 19 sort of make up the bulk, probably 85% of EGFR mutations, and those are sort of the classical sensitizing mutations. And then there are a bunch of rare mutations, and I would kind of classify them as potentially sensitizing to the traditional EGFR TKIs, and those are like exon 18 mutations like G719X, L861, X, S768I. Those are still sensitive, although albeit probably intermediately sensitizing to EGFR TKIs. But 10% are these exon 20 insertions, which really are not sensitive to the kind of traditional EGFR TKIs. And so there have been kind of now, I guess, a few years ago, 2 approvals in this EGFR exon 20 space. And so the first approval is amivantamab. It's a drug that I mentioned before. It's an EGFR MET bispecific antibody, and this is given by itself after chemotherapy. Sorry, this looks small. It's even small for me to read up here, but it really did look to be active in patients with EGFR exon 20 insertions. I think I have a waterfall, yep. And so looking at sort of patients treated, there are different types of EGFR exon 20 insertions, but it did seem to be effective against all the different types of EGFR exon 20 insertions. The response rate was 40%, median PFS of 8.3 months. So I think, again, and we'll talk about this at the end, I think unique to amivantamab is both EGFR and MET side effects, but generally well tolerated. It is an intravenous medicine, but a good option post-platinum-based chemotherapy for these patients. The other drug that's approved is mobocertinib, so it is an EGFR TKI that targets exon 20, and similarly it was assessed post-platinum-based chemotherapy, which is still first-line standard of care for these EGFR exon 20 cases, but this was given afterwards and also looked active. So I think response rate was probably closer to 28% when we look at the kind of standard doses used. Median PFS was 7.3 months. Duration of response was actually quite long with this agent. I think a big Achilles heel for these exon 20 inhibitors is CNS penetration. You can see that responses are lower in the CNS, and so I think, I'm going to talk about potential upcoming EGFR exon 20 inhibitors. I think, for the EGFR space in general, up to 60%, north of 50% of patients will ultimately develop brain metastases, and of course we know that causes a lot of morbidity and mortality for our patients, and so, as we assess these novel therapies, we're really going to need to understand the CNS efficacy of them, and really that's how we're going to cross-compare and ultimately choose which agents to use for our patients. So 2 emerging EGFR inhibitors that are not approved but in clinical development. One of them is CLN-081. The new name is zipalertinib. Response rate to that was about 38%, median PFS of 10 months, and this was again studied post-platinum-based chemotherapy as first EGFR TKI for exon 20. And then there's also sunvosertinib, which has a similar response rate. And then, there are other drugs. There's a Blueprint drug, Bayer drug, other ones. So I think for a small niche of the pie, we have a lot of emerging options. So we will see which of these, demonstrate efficacy in later line studies. And so what are the outstanding questions for EGFR exon 20? I think one outstanding question is sequencing. I mean, we know that this is a driver mutation for these patients, and so one is line of therapy where, can we move these targeted therapies earlier, by giving them first prior to chemotherapy? I think we're sort of waiting for, the amivantamab sort of chemotherapy combo study is, so first, can we move them up? And I think we're sort of waiting for drugs that have clear efficacy that is better than platinum-based chemotherapy to feel confident about moving those to the first-line setting. I think one question is combinations. Can we combine chemotherapy with the targeted therapy, and would that be appropriate or better? Excuse me, first-line chemotherapy, first-line treatment for these patients. And then, of course, we're really looking at these newer exon 20 inhibitors. If they are more effective, can we sequence them to the first-line setting? And then finally, to end on adverse events, I think in clinical trials, as PIs for clinical trials, we sort of often can brush over grade 1 or grade 2 toxicities, but these can be quite, significant for our patients. And so I think being able to manage them as best as possible is really important. And sorry for the pictures early in the morning, but, acneiform rash and skin issues are really classic for EGFR toxicity. It is a known EGFR wild type inhibition adverse event. I think always important to think about early intervention for these, and then mucositis as well. I think we've seen this with the EGFR TKIs to some degree, but also some of the ADCs, and I think this can lead to weight loss and anorexia and issues for our patients, and so I think really important to address those as well. And I think timing of things, so you can see this sort of graph where rash might come out first, but things like paronychia might need a little bit more drug exposure to come out, and so being aware of the timing of things and kind of educating our patients is really important. So paronychia, I think that this is a really tough one to treat for my providers out here. I think kind of good nail care, vinegar soaks are things that, proactive sort of cleanliness and short nails are important. I think it's a real challenge. Once things get severe, I think becoming friendly with one of your local dermatologists is really helpful, because I think they have a lot of different potential options for patients. But again, they seem small, but if any of us have had a hangnail or a little nail infection, we know that that's really kind of bothersome to quality of life. For rash, I think topicals are sort of my first go-to, thinking about topical steroids, and then if we see sort of more pustules, doing a topical antibiotic. I'm pretty quick to give oral antibiotics as well, because I think, again, this is really bothersome to our patients and can be really well managed and controlled with the appropriate medications. And I think there's obviously escalation with potential steroids or oral steroids or other oral antibiotics if needed. But again, being knowing a local dermatologist and knowing when to refer is important. And here's just, and this is for mucositis. I think my best treatment is, knowing which pharmacies can compound dexamethasone rinses, which I think can be really helpful for our patients, saltwater rinses, baking soda rinses, and then sort of escalating from there. But getting on top of that early is also, really important. So peripheral edema, this is a really tough one. So all of the MET inhibitors, this is certainly a class effect. It's unclear in terms of sort of why it happens. All of us, I'm sure, have tried diuresis, which really isn't effective for this. I haven't even, dose holds or dose reductions can be sort of variably effective, but I think, sort of supportive care. I've actually had some help with referring these people to lymphedema for wrapping and kind of lymphatic drainage massage, but it's really tough, and I think this can be, I've had cases of kind of severe hypoalbuminemia and peripheral edema that have required us to discontinue a drug that's working, so something that we do need better treatments for. And then finally, pneumonitis. This is a class effect of many anti-cancer treatments. Of course, we do see this with the EGFR TKIs. There's probably a higher rate of this with some of the ADCs, with trastuzumab deruxtecan in particular coming to mind. I think early, understanding that this is a risk for our patients, and it's especially challenging in lung cancer where our patients probably have shortness of breath and cough to begin with, but any change in those symptoms, low threshold to scan, low threshold to hold treatment, and start empiric steroids. I think this is something where if we are good and diligent about identifying early, we really can reverse this process, but obviously it certainly can become fatal if left untreated for too long. So I think important for us to all remember. I think, again, just saying that it's any anti-cancer therapy can cause this. There are, potentially some enrichments in Asian populations, smoking history, potentially a risk factor. I've had actually some success with say we get pneumonitis with one EGFR TKI. I have been able to sort of change to other TKIs gingerly and slowly. I've also had kind of considered retrials with steroids on board. So I think that there are ways to manage this, but I think getting colleague assistance and kind of talking through it definitely makes sense. And then, I think the infusion reactions with intravenous amivantamab, I think that these are largely, very common. More than half of patients will get them. But I think very, sort of in the grand scheme of things, manageable. I always, when I give amivantamab, I just tell my patient, you will react, just so that they are aware and say, once you start to feel something, please alert the infusion nurse. You stop the treatment. There's a pretty clear kind of algorithm for treatment using antihistamines, antipyretics, steroids, and potentially pre-medication. And I think this is why that first dose, if anyone has used this compound, is split, where you get part of it, a smaller amount of it day one. That's when we see the reaction, and then most patients get the bulk of it on day two and don't react. And so I think it's something that once you have experience with, or if you have experience with Rituxan or any of those other sort of antibodies that cause hypersensitivity, it definitely is manageable. So really my conclusion, so I think for acquired resistance, mechanisms of resistance to osimertinib are diverse. And, if there is an acquired mutation, there might be a survival benefit with targeting it. So please target and personalize therapy. We don't have any approved treatments post-osimertinib at this point, but I think a couple that are sort of in the queue to potentially be approved and available for our patients. And what's great about them is I think that they might be able to transcend mechanisms of resistance. I didn't mention it, but, the ADCs like patritumab deruxtecan can work if patients have C797S, MET amplification, so it is something that could be more diversely uptook. Sequencing is going to be challenging, especially with kind of the change in standard of care. I'm really curious to see if, FLAURA2 and chemo, osimertinib is sort of taken up by patients and providers. But I think, so things are kind of changing lines and sequencing is becoming challenging, but it's a good option to have. And I do think risk stratification and risk adaptive therapy is really going to be key. I think right now we treat all of our EGFR mutant lung cancer patients the same, all of our ALK positive patients the same, but I think there needs to be more nuance. We know that EGFR mutant lung cancer is a heterogeneous disease, and so treating patients according to their risk, I think, will be the future. Exon 20, I think we have some good options that are approved for use after chemotherapy. I think we're looking to some of the new options to see whether those can be utilized and whether the ones that we have can potentially be moved to the first-line setting. And then I think, we're becoming more and more familiar with adverse events of EGFR-targeted therapies, but I think early identification, early intervention is really key, and pneumonitis being one that's very important to recognize and intervene early. Thanks for your attention.
Great review. I don't think there's a single stone left unturned, Helena. We now have some time for questions, but before we jump in, please take a moment and participate in the post-session survey. which will appear if you scan the QR code for the meeting and go to the URL list on the screen. There should be about 4 questions, and they directly pertain to Helena's presentation. So if you've been paying attention, you should get 100%. The survey is completely anonymous, and we definitely appreciate your participation. Eddie, you want to start off?
Yeah, just to start off, because I have a question that I think sort of illustrates some of the problems, the difficulties that we have in the resistance setting. So I have a patient who was basically referred to me because they were moving, and they had been noted, in addition to a sensitizing EGFR mutation, to have overexpression of MET at the time of resistance, and had started a commercial MET inhibitor at that time. So by the time I received them, they have now 2 TKIs ongoing. They have evidence of progression, and there is a BRAF gene rearrangement in addition. And unlike many in the audience, I've had periods in my life where I did do laboratory work where we were able to give yet another TKI in settings like this, and the Western blots often looked great. And for those of you who have not done these experiments, what you generally then do is you try it in mice, and your toxicity output is generally whether the mice lose weight. Otherwise, you don't have much of a sense. And the question that comes up is when am I tinkering too much based on what the data is, and what is the sort of anticipation of a practitioner in practice, knowing that this is sort of an N of 1 experiment. There's not going to be a clinical trial specifically for this patient. What are we supposed to do?
I think that is a great question. I think it's, one, I guess first is phone a friend. I think all of us many years in still, ask questions and, to our colleagues. And so I would definitely, that'd be sort of an email to, an email chain. I think, the sort of one thing, so I think the MET amplification, I think reasonable. There is sort of, pretty significant body of work that says that you can combine EGFR and MET inhibitors. So I might feel more comfortable doing that. I think as we get farther and farther kind of removed or sort of later in the treatment course, I become more hesitant. I think that one thing that I mentioned is that resistance is often subclonal, and especially when it gets complicated, or even if you do that first rebiopsy and you see a BRAF fusion and MET amplification, or maybe even ANSET C797S, then I think it becomes really complicated, like which of these is actually driving resistance, and I think it can be hard. I think in that setting, when we see sort of a complicated mess, I actually think that would be a person I'd probably recommend for chemo first. I think the idea of like, don't forget chemo works. And so I think it's something that we go a little cowboy with these different things, but I think, I think certainly after the MET amplification, I would have done chemotherapy. I think one thing that you can kind of look at is if you're getting liquid biopsies, you can look at the variant allele frequency. The EGFR percentage, that's the clonal, that's like sort of if you see that at 3%, that's the tumor. And if you see things at really low frequency, those are likely, they might be present, but they're not likely driving resistance. But I think, just, sticking to things that I think that there are safety and efficacy data, phoning friends, and then, remembering that chemo is our friend too, and it works.
Yeah, just a last comment. So the patient came in telling me that he was supposed to now get, in addition, a BRAF inhibitor and MEK inhibitor. So it's there's a lot of information out there, but it's hard to know how to navigate. Thank you.
Did you tell the patient, Eddie, that they'll have a lot of toxicity with all these TKIs?
Hopefully not all 4 at once. Yeah.
I told them about the mice losing weight, yes.
So we're getting questions from our online viewers, particularly about small cell transformation. Topocyte platinum, of course, would be the standard, but what circumstances would you continue OC with that? And conversely, would you use immunotherapy as you might do with the de novo smoking-related small cell?
Yeah, this is a little bit of a data-free zone. Personally, I think we have the Orchard study, which has an OC durvalumab arm that hasn't read out yet, so we'll look to see that. But Because I biopsy almost everyone post-osimertinib, I actually see a lot of mixed histology where I'll see adeno and small cell in the same tumor. And so I do think that when tumors transform or cancers transform, it might be heterogeneous. And so I have actually mostly continued the osimertinib and proceeded with the EP because I think, in small cell, the addition of durva to atezolizumab is pretty small. We have really good data that, for EGFR mutant cancers with low tumor mutation burden, that, IO isn't so helpful. And so I do think I get more bang for my buck with continuing the OC. But I think you might get different answers from different
I think
people.
there is a cooperative group trial now that's going to look at
Yes.
immunotherapy with it, but stopping the OC in that
Yeah.
circumstance. Yeah. Barb?
My question was actually very similar. I've had a whole run of small cell transformations, and I think I've had 4 in the last 2 months.
Wow.
And 2 of those were actually asymptomatic, and I just did it pre-Mariposa 2. And I think it's really important to keep the OSCE going. If you stop it, their brain mets go crazy.
I think you're exactly right. I think that especially if you're biopsying in the setting of oligoprogression, there's a lot of adeno still there, and especially if
Yeah.
they have brain metastases and that are stable on osimertinib, I think that's a good, reasonable thing. I've had people who have oligoprogression, I biopsy it, it's small cell, or maybe it's mixed. I might just, radiate that spot and continue the OC. I think as we see more and more of this, we're going to need to have a better, sort of standard paradigm. But yeah, I think continuing OC makes sense.
I think in the last 2 years, I've had at least 2 individuals who had small cell progression, but as limited small cell. The other sites of disease were still responding, but it was the primary or near the primary and nodal disease, and I treated them like limited. I've given them chemo and radiation and continued the OC for everything else. What's your general workup for somebody who's manifesting progression? Are you doing liquid biopsy first and then tissue first, liquid, or both together? I think Eddie highlighted the complications of multiple potential pathways of resistance, but I'm going to pose a question to you as well in that regard.
I mean, I think the easiest or kind of the answer is do whatever is available to you. I think if liquid biopsies are more tumor tissue biopsies are hard to get, they take months, or the patient doesn't have an accessible tumor, then do the liquid. I think we have the fortunate sort of being in an academic center, I send both. I think liquid biopsies are less ideal because, one, they don't determine histology, so we wouldn't be able to identify histologic transformation on them. And then for some of the acquired alterations, liquid biopsies, at least now, the technology is not as sensitive to detect fusions or amplifications, and so you might miss some stuff there too. So I think, if possible, do a tumor tissue biopsy, but I think if what you have is liquid available to you, that's reasonable too.
So the sensitivity isn't good, but the specificity is fairly
Absolutely.
good. So if you
Yeah.
find it in the liquid,
It's
most
there.
likely it's real. So I have a similar situation to Eddie. I have a patient who has progression, more than localized, nodal disease, also the primary site, scattered pulmonary nodules. Liquid biopsy shows the original mutation, C797S and BRAF mutation. Do you base your decision on the allele fraction? Do you go with something, or do you just hang it up and go straight to chemo?
Yeah, I mean, I think the more complicated it is, then we're really just guessing. And I think, again, chemotherapy works. And, I think I'd hate to, not deprive the patient of that possibility by sort of being a little bit, cowboy about figuring, what to target.
We're running low on time, but I do want to ask 2 last questions before we go to our debate. Why do you think Asian ethnicity is at higher risk for pneumonitis? Any hints on that? Or I gather they approach it differently from...
I mean, I think that there is, sort of data, like think about irinotecan and different ethnicities. I think that there are, sort of genetic sort of things that we don't understand that predispose us to risk. And so, I don't know what it is, but I think it is real, and they're certainly more attuned to it because of so, but I don't know.
If you have a patient who's developed pneumonitis, they've responded nicely to steroids, they're weaned down, they still have plenty of tumor, would you re-challenge with steroids on board, or would you switch to another agent?
Yeah, I've had, unfortunately, a bunch of those cases. I have tried to switch, like if the pneumonitis was significant, like required hospitalization or oxygen, supplemental oxygen, I've just switched to chemo, just to sort of control the disease. But I think I have had, switching TKIs I've had better luck with. I have tried to retry with steroids on. I'm kind of like 50-50 in terms of I've had pneumonitis recur. So that's more dangerous, I think.
Another area where we need more data and
Yep.
more study. I want to thank you. This has been phenomenal.